Okay, ladies and gentlemen, so we can start our later session, and I'm very honored to chair this thematic session focusing on rehabilitation, and we are very pleased to welcome Professor Jennifer Legibel, who is a senior physician in medical oncology at the Dana-Farber Cancer Institute and professor of medicine at Harvard Medical School. Professor Legibel is internationally recognized expert in breast cancer care and integration of lifestyle interventions such as exercise, diet, and weight management. And her research includes very landmark trials which explore this impact of lifetime intervention of survivorship and treatment efficacy. And she has guided numerous juniors, faculty, and trainees, and she earns 2021 ASCO Hologic Endowed Woman Who Conquered Cancer Mentoring Award. So it's a very great honor to welcome Jennifer here.
Thank you so much for that kind invitation. I'd like to thank Dr. Sidlak and the organizing committee not only for inviting me here, but also for being wonderful hosts. I've learned so much about Slovakia in this short time that I've been here. It's really been wonderful. I'm excited to kick off this second session as we think about survivorship and taking care of the whole patient. We learned a lot in our first session about taking care of people with cancer is not just giving cancer treatment, chemotherapy, surgery, radiation, but caring for the whole patient. And I'm going to speak for the next few minutes about the importance of cancer rehabilitation, really helping people to keep their strength and to be able to keep their function through cancer care. So what I hope to do first is to talk a little bit about disability and how cancer impacts people's ability to live their lives, do their work, care for themselves and their families. About how exercise can be a powerful strategy to help people maintain their function throughout their treatment and beyond. And then I'll finish by talking a little bit about how do we get people to be active and to exercise after a cancer diagnosis. So, all of us who treat people with cancer recognize that although the medicines that we use and the surgeries and the radiation can be life-saving, they also have a profound effect on the lives of the people who receive them. There are many both short-term and long-term effects of treatment that affect people for many, many years beyond their cancer diagnosis. This first study on this slide looked at people who had been treated for cancer at least 4 years ago. So they had finished their therapy some time ago, and looked at how frequently they were still experiencing the side effects of their therapy. It was a fairly big study, almost 1,400 patients with cancer, about half men and half women. And they used the EORTC QLQC 30. It's great to hear that you all have been involved with the EORTC work. What they found first was that the people who were likely to still be having symptoms were often older. Women, for whatever reason, had a higher risk of still having symptoms in the years after their diagnosis. Certainly having received chemotherapy as part of your treatment was a risk factor, and also individuals with obesity. In looking at what were the symptoms that people were experiencing, you see that one of the most frequent was loss of physical performance, people's ability to do the things they wanted to do. And what you see is that that was almost a third of these long-term survivors, and that quite a few of them were severely, very, or at least moderately impacted by this loss of physical performance, as well as fatigue, which often is hand in hand with loss of physical performance. We also recognize that there is a very clear relationship between physical functioning and frank disability. This was a small study on this slide, but it looked at individuals who were starting treatment for lung cancer, and it looked at how quickly they were walking as a measure of their functional status. And what it showed was that people who had a slower walking pace were more likely to become disabled. They had shorter disability-free survival time. They also spent more time in the hospital if they had slower walking speed, and their overall medical expenses were higher. So really showing this connection between their physical function and their disability in the years following. One of my postdocs was very interested in looking at how common disability was in cancer patients. And so he did an analysis using data from the Behavioral Risk Factor Surveillance System, which captures information about cancer diagnosis and symptoms in the US population. One of the really important pieces of tracking in cancer diagnoses in a country and understanding how they impact outcomes. So he was very interested in looking in this big database how frequent disability was. He looked at mobility disability, which was reported as a serious difficulty in walking or climbing stairs. And he compared individuals with cancer to the general population. He found a couple of things, that the cancer patients were a bit older, found that they were a little bit more likely to be women, they had a little bit higher history of smoking, and they were less physically active. So these are all things that could impact ability or disability. But he found that almost 28% of patients in the United States with cancer met this definition of serious difficulty in moving, which is a really high proportion. And this was much higher than in the general population, where that was about 13%. He also found that physical activity was very tightly linked to mobility disability, and that of patients who reported that they weren't engaging in any regular exercise, almost half of those people met this definition of mobility disability, compared to only 18% of people who regularly exercised. So really showing this tight connection between disability and inactivity. He also showed that this was found really across different cancer types. So you can see all the different cancers there, and all of them, people with cancer were more likely to have disabilities than people who didn't have cancer. But there were some cancers, and I think not surprising, we know that there's a number of people in this room who do research in pancreatic cancer. The treatment for that is very, very toxic, often with extensive surgery. That cancer linked to a much higher risk of disability. Also, cancers of the bone, brain, and leukemia were amongst the cancer types most frequently linked to disability. He also, not surprisingly, found that disability was highest in people who were undergoing therapy, so people with advanced disease or receiving their potentially curative treatment, and that people who had pain. And I think we'll hear a bit later from some of our rehabilitation colleagues about how important it is to treat pain, because it really does impact people's ability to move. So those people who reported pain as a part of their cancer were also much more likely to report disability. So the question is, how can we support physical function and help prevent disability in patients with cancer? And this was one of the questions that we sought to answer through the American Society of Clinical Oncology when we put together a guideline a few years ago looking at recommendations for exercise, diet, and weight management during cancer treatment. So the question that we sought to answer with this work was for adult patients who were undergoing active treatment for curative intent with things like chemotherapy and radiation, what do interventions, exercise, diet, or weight management achieve for a patient in terms of outcomes related to cancer treatment, quality of life, and cancer control? There's a couple of important things about this guideline. It only focused on adults, so it doesn't involve children. It really focused on people receiving treatment for curative intent. Now there is much more information from Anna May's group and others about the value of exercise and other interventions for people living with advanced cancer, but that information wasn't as prevalent when we did this guideline. And the other piece was that we were really focusing on interventions. There are many guidelines that have looked at observational data about people who exercise versus people who don't. But we know that your exercise and your diet and your weight and sometimes your smoking are all intertwined. And what we were interested for this guideline was for an oncologist looking at a patient that you're prescribing chemotherapy, what can you tell them to do that will help them feel better, stay more mobile, and hopefully avoid a recurrence of their cancer? So this was the process we followed. We did a very thorough literature review of all the randomized trials that were reported in systematic reviews, meta-analyses, or large trials that were not incorporated in those documents that were published between 2001 and 2021. We were looking at aerobic and resistance exercise, diets and special foods, and then weight management. We also had an expert grade the quality of the data to make sure that we were putting the same level of rigor to this as if we were deciding what kind of chemotherapy or surgery patients should get. What we found when we did this analysis was that there were 52 of these large reviews, and almost all of them focused on exercise during cancer treatment. There was much less information about what people should be eating or whether they should go on a weight loss program, but there was very solid evidence about exercise during cancer treatment. And as a group, looking at that evidence, it was very clear that there was consistent evidence that oncologists should be recommending aerobic and strength training exercise for all patients getting cancer treatment, chemotherapy, radiation, surgery. And the reason for that was that exercise was consistently shown to reduce fatigue, preserve fitness, which is one of the things we've been talking about, and physical functioning as well as strength. And in some populations, mostly breast cancer, where a lot of these data were collected, an exercise program would also reduce anxiety and depression. And we felt that the evidence was sufficient that we would strongly recommend that exercise become a part of the treatment for patients with cancer. I'm not going to spend time on this, but I just want to show you that when we were making these considerations, they were based on hundreds of studies involving thousands of patients with cancer. And so very, very high quality evidence. Now we also looked at what about people in the perioperative period. And in this situation, we found that there was less data supporting the use of prehabilitation, at least in this exercise review. We felt still that people could recommend this, but there's just not as much information at this point. So I think really still an area of very important active research to better understand if you start exercising even before you start the cancer treatment, will that help people end in a better place? So still a bit to learn. The other piece that we evaluated as part of this work was, well, is exercise safe for people who are receiving cancer treatment? Because I think we heard a little bit in our very first speaker who had recorded the presentation that not that long ago, people were told, you should rest during your treatment. It might be dangerous for you if you exercise or raise your heart rate. So we were very interested in evaluating the safety of exercise, and in fact found that there were many articles that evaluated the safety of exercise, and in fact there was almost no toxicity. There were a few places where people had sprains or had fallen, but the rate of toxicity was much less than anything we would consider another treatment for cancer. So we also concluded as a group that people should always consult with their medical providers, but for most patients who were undergoing treatment for curative intent, that exercise was a safe treatment modality for them. Now, what we told people was that you should exercise, but we didn't prescribe specific exercise for patients. And that work was actually done by another group called the American Society, or the American College of Sports Medicine. The time difference is catching up with me a little bit, but the American College of Sports Medicine had convened an expert panel a few years before the ASCO report. And their goal was to look at the same type of data, but in this situation, develop fit prescriptions. So this was a group largely of physical therapists and exercise scientists, and so they looked at all these randomized trials to determine how much exercise does a person need to do to derive these benefits. What should be the frequency, intensity, time, and type of exercise that provides value? They first found that exercise had many of the same benefits that we had found: anxiety, depression, fatigue, physical functioning. But they went a step further and developed these very handy prescriptions for how much exercise did a person need to do. And in particular, looking at physical functioning, you see that they came up with a dose of aerobic exercise, of resistance exercise, or of a combination. And I think this is a very good place for us to start with when we're counseling our patients for what their goals should be if they're wanting to preserve their physical function or improve their fatigue. We now have some benchmarks that can help us figure out where they should start. So one of the other questions we asked through the American Society of Clinical Oncology effort was, well, how much exercise are people doing? And I recognize this is a US-based study, and I see how much more people walk here. So I think you are probably in a better starting place than our patients sometimes are. But we were very interested in surveying patients to ask them how much exercise they were doing, as well as, do your doctors actually talk to you about exercise as a part of your cancer treatment? So this was a survey that we conducted in 2019. About a third of the patients had breast cancer. They were divided, so about 2/3 of the patients had an early stage cancer, about a third had later stage cancer. And then you can also see that there were a variety of, some patients were getting treatment, some people were done with their therapy. What we found was that about half of the patients that we surveyed really said that they did little to no exercise at all. In a given week, they had less than one, which is 0 sessions of anything that they would consider exercise. And then there were another about 25% with only 1 to 2. So a lot of room for improvement for us. The other question we asked them, well, was anyone talking to them about exercise? And in fact, in the US, we found that almost half the patients, their doctor at least asked them if they were exercising or told them that exercise was important. So this was some progress that we were making. But very few actually received any kind of a referral to an exercise program. But we found that if the doctor actually mentioned it, people were more likely to start to make changes. So we found this was a very hopeful thing, that even mentioning exercise, talking to your patients about it was a good start. I want to pivot a little bit now as we think about, well, how do we get people to really start to adopt exercise behaviors, and what could that achieve for them? And I think many of you may be familiar with a study that was presented at the American Society of Clinical Oncology meeting this year called the Challenge Trial. This was the largest exercise trial that had been conducted. This was a phase 3 study that was looking at whether a structured exercise program for cancer survivors could actually reduce their risk of dying from cancer. This was a large study. They meant to enroll about 900 patients, and they were divided into this structured exercise program versus a health education program. I just want to call quick attention as we think about, well, how do we get our patients to do this, to really engage in exercise, to look at the kind of program that they used. So they included both behavioral support and then they worked with the patients. So they had trainers at each of their sites that provided behavioral sessions to patients, talking about why it was important to exercise and what they should be doing. And then the people exercised with the patients in a facility very much like the facilities that you all have in your cancer institution. So this was the exercise program. It extended over 3 years, but the first year was much more active with the patients working with the coaches, and then that kind of graduated over time. This study, again, enrolled almost 900 people, but I think one of the limitations of this approach was that it took them 15 years to find those people because you had to live close enough to a cancer center to agree to be in a study for 3 years where you needed to come in and meet with someone. You can see here also that the adherence to this program was pretty good when people first started, but then tended to tail off over time. Coming into a place, people get kind of tired of doing that after a while. But this type of exercise program worked. You can see people started off exercising about 3 hours a week, and that went up to about 6 hours a week if you were in the exercise group. People were able to walk further. They had better cardiorespiratory fitness, and they felt better. And I think the most exciting thing about this study was that for the first time, exercise was shown to actually reduce the risk of cancer recurrence. There was an almost 7% difference in recurrence risk at 5 years, as well as an even larger difference in overall survival. So incredible, incredible. This is better than most of the drugs that we use, seeing this benefit of exercise for these people. So I want to just talk for a few minutes, and then I promise I'll finish because we need to keep moving, about how do you really bring this to people? Because I think that the challenge study really shows us the power of exercise and the value, but also some of the complications here. 15 years to enroll 900 patients, and then only about half the people coming to the sessions in the later years. Can we do better to engage our patients in these behaviors? So this is a study that we have led at Dana-Farber. It's called the Breast Cancer Weight Loss Trial. So this is not just focused on exercise, but it is a comprehensive lifestyle intervention that enrolled 3,180 women from across the United States and Canada and randomized them to a lifestyle program that was completely based on telephone coaching. 2-year project trying to help people exercise more and cut their calories. So 3,180 patients who were enrolled from 637 places. So we did not have a coach or a gym at all of those places, but we did our counseling over the phone. I do also want to point out that we enrolled these 3,180 women over 4.5 years. So much, much shorter time period than the 15 years it took to enroll the colon cancer patients. And this approach worked really well to help people lose weight. We had about a 6% weight loss in our intervention versus control group. About 50% of our patients lost at least 5% of their body weight, and about 20% lost 10%. But it didn't work quite as well for the exercise. People exercised more, but we were trying to get people up to 150 minutes of exercise a week. And you can see that at the baseline, our median minutes of exercise in both groups was about 0, which again, when you think about the importance of exercise for cancer patients, it was a little bit breathtaking that half of our patients were doing absolutely no exercise when we started. We were able to improve that to about a quarter of the patients that were not doing exercise in the intervention group versus controls. But we still, this is the slide, we were still only able to get patients up to our 150-minute mark in about 37% of our weight loss intervention group versus 23% in control. So an improvement, but not to the level where I think we see the improvements in the challenge trial. So I'm just going to leave you with where our work has headed now, which is really using telehealth to help our patients increase their exercise. So still using this distance-based approach, but doing this in a way where the coach and the patient can work together, not just for the behavioral part, not just giving people goals and having people trying to overcome barriers, but actually working with patients. So this is a new study that we are launching in conjunction with the University of Pittsburgh, as well as the American Cooperative Group System, that will take patients who are starting chemotherapy for any solid tumor and have them work with a coach throughout the duration of their chemotherapy. The intervention that we will use is all based on a tablet. They are paired one-to-one with a coach. They'll work with them twice weekly. We do send them exercise equipment. We're going to use a bike, but now we're going to use steps, some of the same equipment we see in your gym, as well as exercise resistance bands to see if we are able to use this approach to keep people active through their treatment. So I know we covered a lot of different things, but I just do want to emphasize just how important this is, how many of our patients experience a decline in their function as a result of the side effect of cancer therapy. Exercise really is the best medicine in this situation to keep our patients strong. Challenge also suggests that exercise may not only be something that helps people feel better, but also helps them to live longer. And now our challenge is to find the best way to bring this to all of our patients. Thank you so much for your attention.
Thank you very much for your wonderful presentation, Jennifer, and for all the work you are doing for cancer patients. And now we will continue with the next presentation. Ladies and gentlemen, please welcome here Professor Josef Ukropec from the Center of Physical Activity and Integrative Physiology at the Biomolecular Research Center of Slovak Academy of Sciences, who is internationally recognized leader in integrative physiology, specializing in skeletal muscle, energy metabolism, and systematic adaptive responses to exercise in the prevention and management of chronic diseases such as obesity, type 2 diabetes. And how we will see, he will present us health benefits of aerobic strength training in TGCT cancer survivors. So the stage is yours, please.
Thank you very much for a nice introduction, ladies and gentlemen. It is my pleasure and honor to be here and share with you some of the results of our studies, and I'm very enthusiastic after hearing you talk, Jennifer. So we studied health benefits of aerobic strength training in TGCT survivors, and this was a cooperative effort with the National Cancer Institute, and specific role was played by Medical University in Vienna in terms of magnetic resonance imaging of these patients, and some important chemical analysis were performed in Palack's University in Holland. So testicular germ cell tumors is most common type of malignity in adult males. It has very nice cure and survival rates. However, it brings toxicities. It affects cardiovascular and metabolic health of the patients, as well as some other toxicities. We know that regular exercise modulates trajectory of healthy aging. We studied this in different kinds of patients, and there is a lot of prospective, large studies being performed all over our globe, showing that higher physical fitness produces all-cause mortality in people. And it's hidden to behavioral obesity and low physical fitness is associated with increased all-cause mortality. So the effect of exercise effect important for cancer patients. It might include some cardiometabolic effects. VO2 max is important. Body weight and adiposity is another important aspect, as well as the systemic inflammation. But exercise can also bring psychosocial benefits to patients. Lower the anxiety, help with the depression symptoms, improve the quality of life. It could modulate the peripheral neuropathy, bring structural and functional changes to skeletal muscles, and affect nausea, bone density, and cancer-related fatigue. The question is if exercise is safe and if it could affect the treatment efficacy, and it looks like that higher chemotherapy completion rate is associated with better outcomes, including treatment efficacy and overall survival. And exercise may have the potential to improve dose intensity by reducing the frequency and severity of chemotherapy-related toxicities. So exercise does not pose safety concern for patients receiving active chemotherapy treatment. However, when designing treatment or trials, we can look at a specific patient, we can think about exercise dose, and multimodal intervention addressing the toxicities alongside with exercise could be very beneficial. So here we studied the effect of habitual physical activity, measured like self-reported habitual physical activity, and the prevalence of metabolic syndrome in TGCT survivors at the National Cancer Institute. We evaluated these two aspects in TGCT in about 200 survivors and 41 healthy individuals. And we have observed that habitual physical activity, so it's an everyday physical activity in these patients, is positively associated with their metabolic parameters such as HDL cholesterol, waist circumference, as well as with levels of testosterone. When we analyzed the metabolic syndrome components or prevalence of metabolic syndrome, from left to right, we have controls, TGCT in patients with less than 3, more than 3, and more than 3 cycles of chemotherapy, and you see increasing prevalence of metabolic syndrome due to chemotherapy treatment. The patients here and controls were age and body mass index matched. When we introduced the physical activity information, you see that high physical activity groups were largely less prevalent in terms of metabolic syndrome in all those groups of patients. However, looking at the stage 1 disease patients, the effect of habitual physical activity was probably the most relevant there, indicating that stage 3 and stage 4 patients might really need a structural intervention. And in here we are only looking at the physical activity in everyday life, which they do self-report. There are recommendations for physical activity of patients by American College of Sports Medicine, and from NIH report we know that at least in the United States about 15% of patients really meet these recommendations. So people of cancer survivors do not exercise in their everyday life. In this small intervention study, we examined the effect of exercise on metabolic health and quality of life of TGCT survivors. The controlled study what lasted for 6 months. It was supervised exercise intervention study in our center, and it was open for the TGCT survivors who received low and adiposity cisplatinum. Before and after 6 month intervention, we did a lot of metabolic phenotyping, including body composition, glucose intolerance, metabolic flexibility. We also checked cardiopulmonary fitness, cognitive functions, and muscle functional capacity testing with the dynamometry. We wanted to see how 6 months aerobic strength training would modulate cardiometabolic health, cognitive functions, and energy metabolism, and how these parameters could be related to the residual levels of platinum in their bloodstream. The study population was composed of 20 exercise, or there were 20 individuals in exercise group and 8 controls. These smaller numbers, it was quite difficult to actually have the controls in the study. Therefore, control patients were actually provided the same kind of exercise intervention after completing the 6-month study period. What we have observed is that 6 months intervention in DGCT cancer survivors lowers the visceral adiposity, it increases HDL cholesterol levels, it specifically improves their cardiometabolic fitness, muscle power, maximal voluntary contractions, stands for MEC, and physical activity index in their everyday life. It also had the strong capacity to lower the residual levels of platinum in their plasma, which really depended on the original levels, the magnitude of the change. And interestingly, 6 months intervention in these patients improved their capacity for the memory recall in the Ray Auditory Verbal Learning Test. And from the heat map, we actually see that improvement, exercise or intervention induced improvement in this kind of cognitive functions is positively associated with change in platinum levels, in cardiometabolic fitness, in support index, fasting glycemia, blood pressure, and many other metabolic parameters which actually are modulated together by simple 6-month intervention. So the 6 months exercise intervention resulted in improved cognitive and cardiometabolic health in these patients in this small study, and was paralleled by reduced plasma platinum, providing the evidence that structured supervised exercise brings multiple health benefits to testicular germ cell survivors. And here I would like to stop. I'd like to thank my wife, colleague, my everything, Barbara. People in the lab, specifically Dr. Martin Schön, Patrik Kumpolec, and Ali Amiri, our very important clinical collaborators from the National Oncology Institute, Michal Mego and Michal Chovanec, as well as Martin Korzak from the Medical University of Vienna, though I did not have the time to show his results from his measurements. And I'd like to leave you here with this pictogram indicating that it's much better to burn calories than electricity, and we have the stairs, just take them. They're there for you. Thank you.
Because both speakers have to go to the airport, please 2 questions for both of them, and then they can leave our conference. Any questions?
It's not really a question, but it would be interesting to see your view. I think that the physical activity is very good for everybody, not just for cancer patients. And it would be maybe very useful to use your results to help the general population to uptake physical activity before they get cancer, or prevent getting cancer.
That is a fantastic point, and I do think that everyone should be more active, because physical activity does not just prevent cancer, but it also can be very helpful for preventing heart disease, and we saw changes in metabolism and memory, and there are so many benefits. That is true that kind of from a prevention strategy, everyone should be more active. Some of this, there are differences in national character, and in the United States, prevention and exercise are things that are hard to get. If it was in a pill, everyone would take it, but it's harder to get people to think about behavior change. And one of the reasons that we've focused on people after diagnosis is that for many people, it's what we call a teachable moment. So people are looking to make lifestyle change at that point. And so there's a bit more, when you're thinking about their behavior, they're in more of a ready state to make a change. But that is, I think this should be part of general health as well. But oftentimes people may, at least where I am from, may not be as ready to make a change until they have something like a cancer diagnosis. A kind of a myocardial infarction for many people is the same kind of thing where people recognize that they need to make a change to be healthier, to improve their outcomes. I don't know if you have a different thought about people here being more receptive to preventative medicine.
I don't think that people are too receptive about preventive medicine, that we have to advocate for this and try to help, but I have a question for you. in the new programs you're developing now, which use intelligent technologies are online, what we see is that the feedback for the patient is important. So he knows that he is doing well and that somebody is watching and helping him on the road. So is there a system of feedback during the intervention?
Sure, and so many of our interventions are still working with a coach. It's just that rather than the patient having to come into a gym, they work with the coach through a telehealth session. So they still are working with a coach that they can see and the coach can see them. We have one study right now that I did not want to go for the whole day, that has been enrolling older women who are receiving chemotherapy for breast cancer. So we have enrolled 200 women so far who are all 65 and older receiving chemotherapy. And they are randomized to the telehealth strength training sessions, so doing strength work with bands. And we were not sure how all of these patients over 65 would do with the technology, but they've actually really liked not having to come in the Boston winters in their cars to the gym. It's actually worked very well, even with this population, to do the training. We have a session where we show them how to set up how to put it on a stand so that we can see them. And so there is that kind of support that's necessary. But I do think the working with a trainer, when in our telephone-based study, I don't think there was enough of an exercise dose. When you're just giving goals, it can be hard, especially with the strength training. People can walk, but they will not lift weights and you worry about their form. So I still think that the bidirectional with a person is important.
Thank you very much for a very inspirative talk. I have a very simple question. Did you observe the effect of time of day when exercise was performed in respect to gender or cancer type? Thank you.
That is actually a fantastic question, and not one that we've answered with studies we've done so far, but we do have another study right now that is enrolling women with advanced breast cancer that we partnered with a circadian biologist. And so women are randomized to 4 groups altogether. One group is an exercise group, and they are instructed to exercise only during daylight hours. Another group does prolonged overnight fasting, so that they don't eat after 8 o'clock and they have a 14-hour fast. And then we're looking at the combination of the two. The main outcome of that study is fatigue, but we're also looking at inflammatory biomarkers and other quality of life measures to be able to look a little bit more at how timing of exercise and eating can affect at least inflammation and symptoms.
So, ladies and gentlemen, let me welcome you, Dr. Petra Slavkova. She is the head of the Department of Rehabilitation at the Faculty of Biomedical Engineering, Czech Technical University in Prague, and Bologna University Hospital. Well, she is, or she has extensive international experiences through her fellowship in Germany and Spain, and has actively contributed to European projects on disability, rehabilitation, and telerehabilitation, what we have heard now. And her expertise spans oncology rehabilitation, rehabilitation, functional assessment, quality of life, and we are very delighted to have her here with us today.
Dobré poledne, přivážení pozdravy z Prahy. Dear ladies and gentlemen, dear colleagues, I'm happy to be here. Again, I'm happy to be here, dear colleagues, dear ladies and gentlemen. I will try to share our clinical experiences. This is the result of our multidisciplinary team, and I am really happy for my rehabilitation team. And at the beginning, I would like to say a few words. I'm a rehabilitation medical doctor, and I'm also PT, it means physiotherapist. And I think that I can speak with oncological patients, I can examine them, I can treat them, but I have to respect them and I have to motivate them. This is the task for rehabilitation specialists. So let's go for it. What's on the program during my lecture? We will speak shortly, don't worry, about disability, and then we will have on the program namely rehabilitation. And this program, well, I will present it to you, is focused for oncogynecologic diagnosis, mainly for ovarian cancer. Then, of course, we have to examine patient at the beginning of our program. We use many functional tests, and then we can treat them. Later, during my presentation, I would like to show how we use telerehabilitation. I will continue with ideas of Jennifer. And in the end, I would like to show our results, what's significant, what isn't. And I have 3 greetings from my team, from my PTs, OTs, and also from my patient in the end of my presentation. So, what's disability? This is one of definition. So this is a definition from Matilde Leonardi, who is a leader in Europe with using of ICF, International Classification of Functional Disability and Health. What's the crucial in rehabilitation and oncological treatment is, of course, quality of life. For all patients, it's necessary to live the same life, the same previous life, before diagnosis of this horrible mortal illness. What's prehabilitation? It's not pre-rehabilitation, it's prehabilitation. It means preventive rehabilitation. This is the set of interventions, and we applicate it mainly before severe surgery, mainly oncogynecological surgery. This operation can last 8-10 hours. So for us, it's necessary to reach functional abilities as soon as possible, and of course to reach the highest degree of functional abilities. Our multidisciplinary rehabilitation team, it's my team. So first of all, I've got 8 rehabilitation medical doctors specialized for this, then 30 physiotherapists. Don't worry, only some of them treat this patient and examine. And I'm proud that I've got in team a few OTs, occupational therapists. Of course, that the really important parts or members of our team is psychologists, clinical psychologists. It's not easy to find them, of course, and to pay them. And of course, nutritionists. So, next slide. What about implementation of basic thinking, basic ideas of rehabilitation into normal clinical life? We are normal clinical rehabilitation department. So of course, multidisciplinary team, it's necessary. And of course, we have to respect at the beginning individuality of the person. At the beginning, during the first examination of our patients, we have to find a common way. We have to establish short and long rehabilitation team plan, I mean. It means we have to speak not only with the patient, but also with family members. Patient and her family is necessary partner for us. So, what about time frame? So, I think the best way is from 2 to 4 weeks before surgery. I will present you our results for 3 weeks intensive rehabilitation program. And of course, continuity of the care. It's necessary to explain the patient that it's okay to be friends, not only during active oncological treatment, but also after finishing oncological treatment. I think that rehabilitation is the best partner for the whole life for our oncological patients. What are the typical problems of the patient before starting with rehabilitation program? First group are physiological and functional problems. Mainly reducing of physical fitness. Of course, we tried to improve mainly cardiorespiratory capacity, respiratory parameter. Respiratory physiotherapy rehabilitation is a really, really important part, mainly for telerehabilitation. Of course, then malnutrition. That's the reason why we really need in our team nutrition specialist. And of course, pain. Pain is the crucial factor for motivating our patient. Second group are psychological problems, of course, anxiety, depression, motivation. Motivation is the crucial word for rehabilitation. We are not able to work with demotivated patient. That's I was speaking about my role like rehabilitation medical doctor. I'm coordinator. I have to say indication, contraindication for my team members, but also to motivate patient. And believe me, I can motivate. I have to motivate all my patients to provide any kind of physical activity. It depends on the choice of our patients. Of course, sleeping, monitoring. The problems with sleeping, it's also the second really limiting factors for rehabilitation. Then the group of social and behavior factors. It's not easy to bring them. You can see our life in 4 bottles. This is the great picture for our addictology colleagues. They want to cooperate and they have to cooperate with us also. So we can explain the patient how it's important to stop with smoking, with using drugs, and with using any other any other drugs. So, of course, it's not possible to forget that we have the patient with many comorbidities. In our group, we had 30 women with oncogynecological cancer. Of course, that these women are older, more than 65. So, of course, that are not healthy. So, what are limiting factors for us to our study? Of course, cardiovascular illness, and then diabetes, of course, and also chronic pulmonary respiratory disease, and obesity or malnutrition again. So we applied many tests. Medical doctors, PTs, OTs, nutritionists, and of course other clinical psychologists. Some of them are objective, some of them are subjective. Because it's really important to have information from the patient's perspective as soon as possible, at the beginning mainly. And that's why we have small conference after finishing our patients, after finishing our examination, and then we can discuss what's the priority from the patient's perspective, what's the priority from multidisciplinary rehabilitation team members. Sometimes it's here and here, and we have to find a common way. It's necessary. So, first group of tests, you can see 6-9 walk test, 5 times sit-to stand test, and hand grip strength test are mainly motoric tests applied by our physiotherapists. Then, HUDAS and ICF are, of course, complex functional tests, if I can say by this way. The first, HUDAS is subjective. It's really necessary to know how are the wishes, needs, problems of our patients. And of course that we use core set, ICF core set, for multidisciplinary examination according ICF. This is the task for the whole team. Other group of tests. We also need information about cognitive functions, about stress. This is the domain for clinical psychologists and also for occupational therapists. Also, CATS index and frailty index are signs if it's possible to start with rehabilitation. Our nutritionists use a special body composition analysis called in-body system. You can see it on the first picture. And this is really useful equipment because at the beginning we have information about massive muscles, and we can prepare the individually program, physical activity, the intensity according one concrete patient. And of course, they have to examine at the beginning and in the end of our rehabilitation program and to compare the results. And of course, spirometry. You can see medical spirometry, which is normally applied because we need information if it's not enough for our patients, intensity. What's on the program, according therapy? Physiotherapists, anything surprising. In the center of our therapeutic program is respiratory physiotherapy, because respiration is the basic element, not for only oncological patients, of course. And then they are focused for muscle strength and for functional training, for mobilization, for training, of stability of the patients. What about OTs, occupational therapists? They can able not only to examine, but also to treat cognitive functions and fine motor skills. Their task, for OTs, is to train self-care. It's necessary for the quality of life to reach the highest degree of self-care training. And of course, we need information about favorite activities of our patients, and some of them still work. So it's necessary to provide pre-vocational and vocational rehabilitation. So it means pre-rehabilitation is in the beginning, and pre-vocational and vocational rehabilitation is in the end. I think that we can speak about rehabilitation like about the bridge. It's the bridge between healthcare system and social care system. What about nutrition? So, of course, that they have to consult. It's necessary to have the consultation about the results after measurement in body analysis, and then we can again to have individual programs for our patients. And from nutrition, it means special diet, for example, or special instruction what to do now, what to do later, according to nutrition. And the last one, least one, is of course psychologist. And we have the possibility for the patient to treat them like psychotherapy, but it's individual task. Sometimes it's necessary, sometimes isn't, to have psychotherapy. What about telerehabilitation here on this place? Telerehabilitation, it doesn't mean not only to have a special experience with modern technology, with assistive technologies. We have many types of telerehabilitation. For example, telephone consultation. It's normal, mainly during COVID time. Individual video calls, for example, through WhatsApp. Online group sessions. We have expert for Feldenkrais method. I don't know if you know these methods. It's more relaxating method providing our occupational therapists. And then it's a few months. We can use and we can apply also Watsu therapy. Do you know it? No. It's combination therapy in water and shiatsu. It's one-on-one. It means one physiotherapist in our basin with one patient, oncological patient. It's really, really relaxating methods. Our psychologists say, and now we are without job. It's really, really popular. We will see results. Maybe for a few months we will have also statistical analysis of it. And of course, we use also more sophisticated methods, like mobile applications. I will speak on the next slide about Spirogym, because we apply respiratory physiotherapy also at home surroundings of our patients. And of course, we apply also elements of virtual reality. Spirogym, it's special equipment, you can see it on this slide, and it's closely connected with mobile, normal smartphone. We can bring it to the patient's room and say many instructions how to use it, and it's possible for them to bring it to their home, and then we are able to monitorize if they are able to cooperate with us or not. So we have many graphs and we can analyze them. What's really important that our patients say, it's like virtual therapist. I think that a physiotherapist or OT therapist is still with me, also at home. It's also great that we have also visual feedback. You can see it, I'm in green line here. on green field, green field. When the inspiration and expiration is good, I mean from the side of the patient, so the patient see this green field. When it's not okay, it's in red color, so it's easy visual feedback for the patients. Now I would like to present you two graphs. Now you can see 1 day of the patient's activity with our spirogeny. It means both inspiration and expiration. You can see, for example, this is the Thursday. So I can say that this patient used spirogym at 9, at 12, and 8 in the evening. It means 3 times a day. Other slides is possible to show us how long the patients will be able to provide respiratory physiotherapy. You can see it lasted only 3 minutes. So 3 minutes in a life doesn't mean anything. So what about our rehabilitation program with our oncogynecological patients? We had only small sample, 30 patients. 23 of them had ovarian cancer, and these women were older, more than 65 years. And what's really important is to say that they will in the hospital for 3 weeks, but in the regime from Monday to Thursday. And each day they have intensive physiotherapy and occupational therapy twice a day. And what's important also to say is the lasting of individual therapy. It's from 20 to 30 minutes. It's enough because fatigue of our patient is necessary to respect, of course. And what about from Friday to Sunday? The patients were at home because social, psychological parameters and so on, it's better to respect them. Not better, it's necessary to respect the wishes of our patients, and they can continue with respiratory physiotherapy, with our spirogym, and also they have many homeworks from our OTs and physiotherapists, how to provide physical activities, physical exercises. And what are the roles of our physiotherapists, nutritionists, psychologists, occupational therapists are together to help the patients improve all functional abilities, if it's possible, of course. What about statistical significant results? I can say it's fantastic because according to motoric functions, our patients were improved more than 70%. Parameters like stress, anxiety, and so on won't be so successful. But I think that it's connected with the length of our therapy, only 3 weeks. So maybe according results of international studies, it lasted a longer cooperation with oncological patients. What about the perspective of rehabilitation and telerehabilitation? We have many questions, of course, because we cooperate, we treat, we extremely motivated patients, but we are experts and we have to say to the patient what to do now, what to do later. So what about best duration of our therapy? What about team structure? What about exercise modality and intensity? And what about using and what about the role of assistive modern technology and telerehabilitation? And now greetings from my team. First, this is the video. 2 real patients, oncological patients, ovarian cancer patients. Okay, the second picture is from my physiotherapist. This is the picture from my OTs. And this is the last slide. I think motto of each rehabilitation medical specialist is less medication, more rehabilitation. Thank you for your attention.
Thank you very much for a very highly motivated presentation. I think many of us has been motivated.
Dear organizer, thanks for invitation. Dear organizer, thanks for invitation. Dear chairs, dear audience, I will speak in the next few minutes about cancer, rehabilitation and rehabilitation, the Austrian approach.
Okay, so in the last presentation in this block about rehabilitation and rehabilitation will be given by Professor Richard Kavanagh, who is the head of the Department of Physical Medicine Rehabilitation in University of Vienna. And he also leads the Comprehensive Center of Musculoskeletal Disorders, and he will tell a presentation about his research in rehabilitation.
Dear organizer, thanks for invitation. Dear chairs, dear audience, I will speak in the next few minutes about cancer, rehabilitation and rehabilitation, the Austrian approach. From our side in Austria. My name is Richard Kavanagh. I am the head of the Department of Physical Medicine, Rehabilitation and Occupational Medicine at Medical University of Vienna, Austria, the General Hospital of Vienna. I am also head of the Comprehensive Center of Musculoskeletal Disorders, and our department is part of the Comprehensive Cancer Center, Vienna. Act information for CV, and at the moment the president of the Austrian Society of Physical Medicine and Rehabilitation, and also of the Austrian Pain Society. It's an interdisciplinary and interprofessional society, and also of Leben mit Krebs, to live with a cancer. 20 or 25 years ago, exercise has been seen as an absolute contraindication for cancer patients. Today, we know more. Our knowledge has changed as a change of paradigm. Today, cancer is seen as a kind of drug for these patients. We know that endurance and strength exercise can help cancer patients to live better and also longer with diagnosis with cancer. We know this from the animal model, but have many ways how to help cancer patients by using the medication exercise. The exercise has enormous effects on metabolism, on immune system, and on vascularization and neovascularization, the whole system of cancer patients. We ever talked about exercise-regulated myokines and adipokines and their effects on cancer patients. Today, we talk about exokines and their positive and beneficial effects on this patient group. And the effects of exercise on cancer prevention and on cancer treatment and cancer survival are so impressive that cancer rehabilitation, cancer rehabilitation, and cancer exercise itself can be seen and has to be seen as part of the cancer care continuum. We can run from cancer in all stages, also in prevention. Today, we know more. Our knowledge has exploded. We know that cancer rehabilitation and cancer exercise for cancer patients cannot only help to improve quality of life, to reduce distress and anxiety, to improve night sleep, to reduce the daily fatigue, to improve libido, to improve quality of life and social participation at workplace, but it can increase overall survival, cardiovascular survival, but also cancer-specific survival. Today, we know that exercise during cancer treatment is effective and safe, rehabilitation is beneficial, effective and efficient. Rehabilitation can be beneficial, effective and safe in many cases, and that pain reduction enables before mobility and targeted exercises during cancer treatment. Today, cancer rehabilitation and exercise for cancer patients is well established. The relevance of cancer rehabilitation is therefore so high that in most cases, cancer has become a chronic condition instead of a deadly disease. Last year, we celebrated the 25th anniversary when we started to exercise in cancer patients, and from the beginning we had all from our patients. We asked them, what are your problems? It was the fatigue, it was the loss of muscle mass, the loss of endurance capacity, the decreased flexibility, the disturbed sensory-motor functions, the cancer-induced polyneuropathy, impaired mental health, depression, anxiety, distress, lymphedema, decreased sexual dysfunction, incontinence, problems with swallowing, problems with mobility, impaired participation, and impaired quality of life. Cancer rehabilitation helps to manage these short-term and long-term side effects of cancer and its necessary cancer treatment. The doctor supervised programs to help patients to return to activities of daily life, to improve their function, to reduce pain and improve the well-being. It can occur at an inpatient basis, at an outpatient basis, at additive, at a telemedicine, telerehabilitative basis. It has an interdisciplinary and multi-professional approach. It's a team process. Awareness is a very important term in this complex. The sustainability, the compliance, the adherence, and at the end, are the modules effective? The effectiveness and also the efficiency. The elements of cancer rehabilitation are empowerment of patients, psycho-oncology, nutrition, physical medicine and rehabilitation to improve the well-being, to reduce pain and to make the patients active and to help them to exercise. And then an interface to occupational medicine. Goals are better and a longer survival, a better quality of life, more self-confidence and a better participation, social participation and a better participation at workplace, earlier return to work. In Austria we have the rehabilitation compass, a guide to find the best rehabilitation place, such as here in Bad Sauerbrunn in Burgenland and in St. Veit-Bongau in Salzburg, Austria. We evaluate also the cancer rehabilitation by using drones with a teleinformatics system, and at our hospital, the General Hospital in Vienna, from the Medical University of Vienna, we've been working the last 26, 27 years in this field. Our most important thing was to show that almost everybody is able to perform regular exercise, even cancer patients and cancer patients suffering, for example, from metastatic bone disease or multiple myeloma, plasmacytoma, and also patients suffering from brain tumors and metastatic brain disease, and also patients suffering from cardiovascular disease. They know how to do this. This is the challenge. 26 years ago, it was a contraindication. There was a change in paradigm about 180 degrees. Today, regular physical activity and exercise is seen as kind of medicine, as a kind of medication in cancer treatment. We started with our first group during adjuvant chemotherapy in breast cancer patients in 1999. It was worldwide the first group when the exercise occurred on the same day of application of chemotherapy application. We were the first who performed regular exercise in patients suffering from metastatic bone disease, but also metastatic brain disease. Our first patient reached an endurance capacity of about 150%, but this was not the goal. 2000, we implemented our first outpatient clinic for cancer rehabilitation in Austria, and we were also the first worldwide who performed neuromuscular electrical stimulation in patients suffering from cancer, but also in patients suffering from metastatic bone and brain disease. At this time, with the intention, the motivation, the intrinsic motivation of the patient to return to work, because her social participation was also at workplace. She had all her friends, all her family at workplace. 2010, we implemented that at this time, first worldwide and unique tumor board for cancer rehabilitation in the Comprehensive Cancer Center of Vienna. We are very proud on this. In this tumor board, we decide not about the treatment of the cancer itself, but about the rehabilitation process in very, very challenging cancer situations of patients. We have also implemented in 2015 a CCC platform of side effects management, supportive care rehabilitation in our Comprehensive Cancer Center of Vienna. And we made the first online conference for breast cancer survivors before the pandemic, the Survivor 2018. This was the worldwide first online conference in real time with the leading experts of our country to help patients from the diagnosis until to the palliation, but especially also for treatment of cancer and rehabilitation of cancer, and also a little bit of rehabilitation of cancer. They had the possibility to hear cancer experts, the leading experts in real time. We also implemented programs to include patients from different, with different problems, who had the problem to include themselves in cancer rehabilitation programs, here for patients not speaking our language. And we implemented also the rehabilitation. The rehabilitation has sponsored with the cancer diagnosis, the modules and measures from cancer rehabilitation start with the diagnosis, and the patient had, for example, in the unimodal rehabilitation setting, to exercise until the first cancer treatment, such as surgery. But there are also existing multimodal treatments with psycho-oncology, exercise, nutrition, lifestyle changes, and so on. Today, we therefore urgently need the collaboration, the joint projects and multi-center studies dealing with endurance and strength exercise therapy in cancer patients, also with other exercises, the studies and our collaboration and cooperation concerning cancer rehabilitation, but also cancer rehabilitation. The same for physical therapies and modalities for cancer patients, especially spa therapy for this patient group, and studies dealing with the effectiveness of the whole concepts and the individual modules, and also concerning their efficiency and sustainability of this use. We are all open for joint projects and collaborations. Thanks. Feel free free to contact me.
Okay, so we will finish this session, and maybe if somebody else have questions for our speakers, so we can proceed with some questions, or maybe you can discuss during the lunch break. Would there be any comments or questions about rehabilitation and rehabilitation, all the speakers we have, especially from Czechman, or maybe you can leave it for, yes, there is.
Just one question, who pays for it?
Thank you for this question. It's a really important question, but it's fully covered from Czech health insurance companies. It's normal part of the treatment of our oncological patients. It's our victory. Hurrah!
Thank you very much. Okay, so now it's time for lunch. Thank you. Okay.